Hello, my name is Anna Graves, and this is my research presentation titled Music Listening for Affect Regulation in Adults with Depression. The prevalence of depression is rising. In 2019, 7.8% of Americans were affected by depression, but that number rose over threefold by the fall of 2020 in response to the COVID-19 pandemic. Affect, the umbrella term for all evaluative or valence states, needs to be regulated for mental health. People with depression make more affect regulation attempts than a mentally healthy population. People with depression tend to use maladaptive regulation strategies like rumination, self-blame, and catastrophizing. Affect regulation is the most common reason people listen to music, and people use more media when they're feeling depressed. Music listening for affect regulation can be effective because music is experienced as somewhat outside of the self. On the other hand, people can have strong emotional responses to music, which can pull them into an emotional experience. This phenomena is referred to as emotional absorption in music. When negative, as in rumination, this could be potentially harmful to the individual. Although potentially harmful, this is a functional use of music and can establish and strengthen music preference. There's been some research into this realm of music listening for affect regulation in adults with depression, but results are mixed as to which strategies transfer to affect regulation through music listening from non-music based affect regulation. My research question is, what is the relationship, if any, that exists between music listening for affect regulation strategies and levels of depression in adults? I had three hypotheses guiding this investigation. One, there will be a positive correlation between level of depression and music listening for rumination. Two, there will be a positive correlation between level of depression and emotional uses of music listening. And three, level of depression will significantly predict rumination and emotional functions of music listening when accounting for demographic factors such as gender, age, music training, and mental health treatment. I applied for and received IRB approval for this study. I used a cross-sectional survey design, and my participants were recruited and reimbursed via Amazon's Mechanical Turk, which is an online crowdsourcing platform referred to as mTurk. Participants viewed an announcement in mTurk and selected the study if interested. They read a brief description, then proceeded to the screening questions for inclusion criteria. These included age over 18 years, located within the United States, and proficient in English. If they met inclusion criteria, they proceeded to an informed consent letter and provided consent by selecting yes, they agreed to participate. They proceeded then to the survey. Following the survey, a 6-digit code was displayed, and they used this code to receive reimbursement through mTurk. Participants completed 3 sections of measures in this study. First, they completed the Adaptive Functions of Music Listening Scale, or the AFML. This is a 48-item scale that has 11 subscales, including rumination, which form 3 composite scores: emotional FML, social FML, and cognitive FML. Next, participants completed the PHQ-9, in which they rated how often they experience each of the 9 symptoms of depression. Lastly, they completed a brief demographic questionnaire with the information that would be relevant to these results. There were 214 responses to this survey. 11 were excluded from analysis for the reasons shown in Figure 1. The final sample included 203 participants who were predominantly white, male, and the average age was 35 years old. The average PHQ-9 score was around 13, which is in the moderate depression range. More demographic details of the participants are shown in Table 1. In my data analysis, I used depression, operationalized as the raw PHQ-9 score, as the independent variable. My dependent variables of interest were the AFML scores, both the rumination subscale and the composite emotional FML score. To test my first 2 hypotheses, I performed a bivariate Pearson's R correlation between PHQ-9 scores and the AFML scores of interest. For the third hypothesis, I used a multiple regression analysis. For this calculation, I included the 4 demographic features listed in my hypothesis. My first hypothesis was supported. This is shown in Table 2 with the green box. This positive Pearson's R value indicates that as the level of depression increases, so does the likelihood that a person listens to music for rumination. My second hypothesis was also supported. This is shown in Table 2 in the orange box. This indicates that as the level of depression increases, so does the likelihood that a person listens to music to perform emotional functions. My third hypothesis was two parts, both of which were supported. The multiple linear regression model predicting rumination with music listening explained 32.6% of the variance in the AFML score. In Table 3, the overlapping green boxes highlight that the PHQ-9 score, level of depression, was the only predictor which reached statistical significance. The model predicting emotional FML explained 38% of the variance. As shown in the overlapping orange boxes in Table 3, the only independent variable to reach statistical significance was PHQ-9 score. In this model, however, musical training was approaching significance. This is shown in the gray box. For both of these dependent variables, rumination with music listening and emotional FML, the finding indicates that level of depression significantly predicts a person's listening to music. The influence of demographic features was likely due to chance. This research has important implications for music therapy clinical practice. This shows that people with more severe depression, which is a large proportion of the people that music therapists may work with, are more likely to use music listening for emotional functions, especially rumination. We know from previous research that functional use of music is associated with stronger preference. Clients' preferred music may carry associations from previous functional use. So, we need to be aware that negative associations with preferred music may exist. We can then be prepared to handle anything that may come up while staying within our scope of practice. Moving forward, research on specific affect regulation strategies operationalized through music listening is needed. Lastly, depression should be operationalized as a continuous variable to gain further insight. I would like to thank the graduate and professional student government at the University of Iowa for their support in this research. Thank you for your time and feel free to contact me with any questions.